Hey, good morning, everyone, and thank you for joining us today for the non-motor symptoms webinar. We're really glad to have both Dr. Goldin and Dr. Lee here with us today. So thank you for taking some time out of your Saturday to join us. A couple of quick updates from the Parkinson Association and a little bit on how to use this GoToWebinar feature. So there will be a question and answer section at the very end. So if you have any questions during the presentation, there are a couple of different ways you can submit those. We ask that you'll hold them to the end, or you can type them in. I'll explain that in just a minute, and then we'll get those answered. So the first one, if you look over to your control panel for the GoToWebinar, there's a drop-down section that says questions. You can type your questions in there. Those will be sent to me, and I'll hold on to the ones that are pertinent to the presentation until the end of the presentation. And any audio questions I'll also answer if you have any issues with the platform. So that's one way, using the drop-down menu. The second way is there is a raise hand function. You can go ahead and click that little button. It'll show up on my screen. And what we'll do is at the very end, we can unmute you and you can verbally ask questions to the presenters. Just make sure if you're using that, please make sure your mic is equipped in your computer so we can hear you. So a couple of other things. We do have another webinar coming up next week on Wednesday, April 29th from 10 to 11, and it will be a webinar on vision and Parkinson's, presented by Dr. Pellet from the university as well. It should be really interesting. We've never really had a presentation like this before, and so I'm going to learn something as well. We are constantly working to get more and more webinars online, so if you look over to your control panel again, there's a handout there that has some available programs as well as some other really good resources, and we're constantly updating those. So if you want to have some more webinars in your life, feel free to keep updated on those and visit parkinsonrockies.org/online programs, and that should have updated lists. So yeah, and in addition to those other handouts, there's an aware and care kit flyer and a medication form from the university as well. So make sure you download those. It will also be included in a follow-up email after the event, and you'll have access to those later on. So without further ado, what I'm going to do is I'm going to transfer over control to Dr. Goldin, and we will go ahead and get started.
Great. Let me try to, I thought I had this pulled up and now it's not here. Here we go.
No worries.
Okay, can everyone see that okay?
Yep.
Okay, great. So my name's Caroline Goldin, and I'm doing this presentation with Teresa Lee, and we are both movement disorders fellows at the University of Colorado, which means that we're board certified neurologists who are getting additional training in movement disorders, which include things like Parkinson's disease. Today we're going to talk about non-motor symptoms in Parkinson's disease. Oh yeah, we don't have any significant disclosures. So as most of you already know, Parkinson's can have an effect on lots of different parts of your body. And this is a picture of someone with kind of a classic Parkinson's syndrome. The four main symptoms of Parkinson's are a resting tremor, so a tremor when your hand isn't doing anything, just kind of resting in your lap, a stooped posture, slowness of movement, stiffness of muscles, and difficulty with standing upright and keeping balance. What you may not know is that Parkinson's is not only these motor disorders that you can see from the outside, but there's also what we call non-motor symptoms, which are the symptoms of Parkinson's that affect things like your thinking, your sleep, your sensation. And so we're going to talk about those today rather than talking about the motor symptoms like tremor and stiffness. The reason these are so important is not because everyone with Parkinson's is going to get all of these symptoms. That's definitely not the case. It's important because a lot of times patients might not recognize these symptoms as being part of their Parkinson's disease and then wouldn't bring them up to their neurologist when their neurologist could actually help them with some of these symptoms. So just to re-emphasize this, not every patient with Parkinson's gets every non-motor symptom. This is not meant to be a look into your future. It's supposed to be informational so that if you do experience some of these symptoms, you could recognize it as potentially being part of your Parkinson's disease. The first thing we'll talk about is cognitive changes or thinking changes. There are a few different cognitive changes in Parkinson's disease. The four that I'd like to talk about are slowness of thought or bradykhrenia, loss of memory or changes in memory, changes in your mood, and also changes in how you perceive the world around you. So first we'll talk about bradykhrenia, the slowness of thought. And what I like to liken this to is sort of like the slowness of movement that you see in Parkinson's disease. Just like there's slowness of movement, there can also be some slowness of thought. And this can manifest as someone asks someone with Parkinson's disease a question, and it just takes them a little bit longer to answer. Some slower processing speed, just takes a little bit longer for them to understand what has been said to them and then say something in response. And people can also have difficulty shifting quickly between different tasks. For instance, I had a patient who was very into woodworking, and he had a hard time shifting between, okay, I want to do this project, to I need to get all of my tools, to I need to start whittling away at this piece of wood. And so back to that woodworker as an example, he had difficulty completing his woodwork because he couldn't shift between those tasks easily. And so what he did is he broke the task down into small chunks that he could shift between more intentionally rather than trying to do it all at once. So he would, write down his idea for what he wanted to make. Then he would gather all of his supplies. Then he would pick the supply that he needed to use, and then he would get to work. What I've also heard from some patients is that this slowness of thought can cause some social difficulties, and that's because of that slowed processing speed, that slowed response time to when people are talking. I've had people say, it's really difficult for me to go out to eat with my friends because they're having a conversation that I'd like to participate in, but by the time I come up with what I'd like to say, they've moved on to something else. And I thought that this patient came up with a really great way to deal with that symptom that they were having. What they did is that they talked about this with one of their close friends in that group. And they came up with a plan that if she had something that she wanted to say, that she would let her friend know so that the friend could call attention to her, give her some time to collect her thoughts, and then could speak and participate in the conversation. If you don't want to have one person do that for you, you can also arrange just with the group of friends, like, hey, if I wave my hand, that means I'd like to say something and I just need another second to be able to get out what I'd like to say. Another cognitive change that can be seen in Parkinson's disease is changes in memory. And there are a few different levels of changes in memory. And this applies not only to Parkinson's disease, but to any sort of memory loss. These categories do. There's what we call normal aging, which is as we get older, we may misplace things a little bit more often. Maybe takes another second or two to remember someone's name. And that's what we would call in the realm of normal. These people would still be able to do things like pay their bills, take care of themselves, things like that. The next level up of memory loss is called mild cognitive impairment. And that means that this person has memory loss that's more than normal aging, meaning we can pick up this memory loss on certain screening tests that we'll talk about in a minute. But despite having some memory loss, it doesn't interfere with their ability to take care of themselves. They're still able to do those things like pay their bills, make their meals, get dressed, take care of themselves. The third category that we would group memory loss into is dementia, and that's a step above mild cognitive impairment. where these patients would have memory trouble that we can see on a screening test, and the degree of their memory loss affects their daily functioning so that they can't do the things that they need to do to take care of themselves. You can see all three of these things in Parkinson's. And again, it's not a guarantee that with Parkinson's you'll have memory loss, but there is memory loss associated with Parkinson's sometimes. So it's important to talk with your neurologist about this if you're noticing some symptoms. It's really important because memory loss can lead to decreased quality of life and often is a reason for nursing home placement when people have dementia and aren't able to take care of themselves. Mild cognitive impairment can affect about 30% of patients with Parkinson's disease at any given time. So I mentioned that there are some screening tests that we do as neurologists to see, do we think this patient has some cognitive impairment that we can see on testing? And there are two that we use most often in the office that you may have heard of or seen. One is called the mini mental status exam. And that's when a doctor asks you questions like, I'm going to say these three words, apple, table, penny. I'm going to ask you again in 5 minutes to repeat those back to me. The other one is called a Montreal Cognitive Assessment, or a MoCA. And this one is studied a little bit more in Parkinson's disease as being something that that we're able to follow over time and see any changes in scores. This is a picture of the MoCA. Some of you might recognize it. There are several different areas of the MoCA. So there's an area that looks at your visuospatial memory, or your ability to kind of manipulate objects in space, your language, naming, memory, ability to keep attention. The MoCA and the mini mental status exam take about 10 minutes to complete in the office. And we call them a screening exam because they can give us a rough idea of if someone is having memory problems that we can see on testing. If someone is having these memory problems and we're concerned, then we may recommend doing a more formal test called a neuropsychological assessment. And rather than being just 10 minutes in the office, this is a 2 to 4 hour test that's performed by a neuropsychologist and tests those same different domains of cognition, but in just a lot more detail. And they're able to pick up on different patterns that could be able to be kind of treated with either medications or behavioral interventions. Sometimes in the neuropsychological assessment, if the symptoms of Parkinson's from a motor standpoint, things like tremor and slowness, aren't treated well, that can impact the testing. So we would want to make sure that the patients are treated really well for those motor symptoms we talked about earlier, so that that doesn't interfere with our testing. If you go into the neurologist and are having some issues with cognition that we can see on our testing, what we also do is we don't necessarily assume that this is related to Parkinson's disease. We want to see, is there any other thing that could be causing this that we can treat or reverse? And there are a few things that can make memory problems appear in people, and common ones in the Parkinson's population are things like infection, even something like a urinary tract infection. Thyroid disease or certain vitamin deficiencies can also affect cognition. And so we would check all of those blood tests to see if there's anything that we need to treat other than Parkinson's disease for the cognitive impairment. The best way to prevent cognitive changes and also to treat cognitive changes is to exercise. I'm sure you've heard this from your doctors too, that exercise is the best thing that you can do for yourself, whether you have Parkinson's disease or not. But we do know that in the Parkinson's disease population, exercise is the only thing that's been proven to slow the progression of the disease. And that's not true just for the motor symptoms, it's also true for the cognitive symptoms. So any activity is great, but the goal would be to get up to 30 minutes 5 times a week of getting your heart rate up. You can do any kind of exercise that you like. We encourage people to find something that they do like, because if you don't like it, you're going to find lots of excuses not to do it, like anything in life that you don't like. I know that the Parkinson's Association of the Rockies has some great resources for different classes for Parkinson's patients, although I'm sure they're not happening right now in the COVID era, but once this all passes, they're a great resource for any classes, and that can also provide a social outlet as well. Speaking of social outlets, social activity is another great way to prevent and treat cognitive changes. Staying engaged with people is really important for your brain. So, I made this presentation before COVID, so go out to lunch when this is over. You're all able to use the internet by getting on this webinar. You can have virtual lunch dates with friends, call people on the phone. All of these things help keep your mind active. Other brain training things to keep your brain occupied, things like crossword puzzles, card games, and reading are also very good to help prevent cognitive changes. There are a few medications that we sometimes prescribe for cognitive changes in Parkinson's disease. There's only one that's FDA approved, but we also use others that have been developed for Alzheimer's that have evidence that they help with cognition in Parkinson's as well. I've listed some of them here, but it's very patient dependent, and so something that you'd want to talk with your doctor about which one would be the best for you. Cognition is not just about how quickly you think or how much memory you're able to have. There's also changes in mood that kind of fall under the umbrella of cognition, as well as changes in how you perceive the world around you. So next we're going to talk about mood changes that can occur in Parkinson's. Depression and anxiety are common, even not in Parkinson's disease, but they can be more common in Parkinson's disease for a few reasons that we'll talk about. I just wanted to start with some definitions of these. So depression would be sadness, loss of interest in activities that you used to enjoy, and it can even manifest as irritability. People might say that they don't feel sad, but they're just a little bit shorter with their loved ones. Irritability is a more common presentation of depression in men. Anxiety is defined as excessive worry, so feeling like something bad is about to happen without objective evidence that that's the case. And apathy can be associated with both of those things or can present by itself, and that's a loss of motivation. So not feeling like getting up, not feeling like getting out, not feeling like making yourself any food, cleaning, things like that. As I alluded to, there are a couple of reasons that people with Parkinson's disease might be more prone to depression than the general population. There's the reactionary depression, which is a grieving reaction. You're diagnosed with this disease that's lifelong, and that is a change in your life and a change in how you might see yourself. And that can cause sadness, understandably. There's also a pathologic reason or actual structural changes in the brain that can lead to depression and Parkinson's disease. So Parkinson's affects the brain by changing different chemicals that help your brain communicate with the other cells around it. And that change can lead to depression as well by changing the levels of different neurotransmitters that are responsible for mood. And both of these can be treated with both talk therapy or medications. Anxiety, or that excessive worry, can be an off symptom of Parkinson's disease. So a lot of patients will say, as my tremor starts coming back, my stiffness starts coming back, before my next dose of medication, I just feel this sense of doom. I feel very anxious and worried. And this is important because if you're noticing anxiety even without those changes in things like tremor and stiffness, that can still be an off symptom and something to talk with your neurologist about. You might need to change your Parkinson's medications, change the schedule, and see if that by itself can help treat the anxiety. There's also that apathy, that loss of motivation that I mentioned. That might be related to fatigue that's associated with Parkinson's disease, and Dr. Lee will talk some about fatigue a little bit later. But also sometimes people with Parkinson's disease may appear like they're apathetic, but not actually be. And that's from that masked faces or kind of loss of expression of the face that can happen in Parkinson's disease. And so if you're a caregiver or a loved one, it's really important to to talk with your loved one with Parkinson's disease about how they're feeling rather than just assume how they're feeling based on the way that their face looks. The last cognitive change that we'll talk about is perception changes. And again, perception meaning just how you see and understand the world around you. People with Parkinson's disease can develop hallucinations. This is more common in people who have some cognitive impairment already, and this can be worsened by some of the medications of Parkinson's disease as well. Again, not everyone gets this. Just important to know that if it happens, it's nothing to feel ashamed about, and it's important to talk with your neurologist about this as well. The hallucinations we would describe as seeing or hearing things that aren't really there. A lot of patients who have hallucinations will say that generally these are pretty friendly hallucinations. The most common things that they see are people or animals. You can also feel like you have a presence in the room, like there's someone standing behind you when there's not. Another type of perception changes would be illusions, and that's when, say you're walking down the street and you pass by a bush and the bush is in your peripheral vision, and for a second you think that that bush is an animal, and you turn and you say, oh no, it's not an animal, that was just a bush. The last perception change that can occur is delusions, and that's a falsely held belief, and that's usually something that happens more in advanced cognitive impairment. And these people might think, oh, someone is trying to come in my house, someone is trying to steal my money, things that aren't true. And again, this can be related to both the advanced stages of Parkinson's disease as well as some of the medications that we use to treat Parkinson's. So it's very important to recognize this if it happens as something that could be related to Parkinson's. There is a range in severity of symptoms of hallucinations. It can range from someone saying, oh yeah, I see a dog, but I know it's not actually there, and it's friendly to those kind of delusionary beliefs that we talked about. And I already mentioned that this is more common if there's cognitive impairment, memory loss, and this can be worsened by medications. Another perception change is called delirium, and this is something that would be important to watch out for if you or your loved one have some degree of dementia and are have to change where you are, for example, going from home to a hospital. Delirium is an acute confusional state where people just aren't sure where they are, why they're there. And like I mentioned, it can often occur when people go from one place that they're familiar with to a place they're unfamiliar with, such as with hospitalization. So that's the outline of all the different cognitive changes that can happen along with Parkinson's disease. Again, I want to emphasize that this does not happen in every person with Parkinson's disease. The important thing to remember is that if you do experience some of these symptoms, to be able to talk with your neurologist about this, because it can be related to Parkinson's disease, and not feel like your neurologist wouldn't be the right person to help you out. So with that, we're going to switch over to some other non-motor symptoms, and let me change this presenter to Dr. Lee.
All right, thanks so much. Let me pick up where we left off. All right, so thank you so much again for having us, and thanks to everyone who's listening. And again, I think Dr. Goldin did a really good job emphasizing that important point that we're just kind of giving you a really broad overview of all the possible things that people with Parkinson's may experience in terms of non-motor symptoms. But again, as you probably know, everyone with Parkinson's disease is different. You know, you might not have a tremor, or you might know people who do have a tremor. So it's kind of the same thing with the non-motor symptoms. Okay, so there are a couple different kinds of sleep disturbances. So one could be difficulty falling asleep, and another is difficulty staying asleep with frequent arousals. And there might be multiple reasons for both of those things. So people might have difficulty falling asleep because they have something called restless leg syndrome, which I'll go into more towards the end. Another reason could be because of poor sleep hygiene, and I'll discuss a little bit more about what that is in the next coming slides. They might have some difficulty adjusting in bed because of rigidity. They might have stiffness and then that slowness. It's kind of hard to turn over, and sometimes that can make it a little uncomfortable falling asleep. And then if there's any anxiety, that can also make it difficult to just get relaxed enough to fall asleep. And then in terms of difficulty staying asleep, one reason for that might be because patients are acting out their dreams. So there's something called RBD, which you might have heard of, or REM sleep behavior disorder. And that's very common in Parkinson's disease. And often it's one of what we call the prodromal symptoms, where it can start happening up to 10 years before someone might even have their motor symptoms. So their bed partner, if they have one, might say, oh, you were kicking and screaming and kind of moving around. And so sometimes that can wake the person up. Either they wake themselves up or their partner wakes them up because they're moving around in bed. Another reason why people can get sleep fragmentation is due to urinary frequency, if they have to keep getting up overnight to use the bathroom. And then another problem is sleep apnea, which just occurs generally in the population. But if someone's snoring or having episodes where they're not breathing, then that can wake them up. So still under the theme of sleep, fatigue is one of the most common symptoms in Parkinson's disease. It can be a little vague. Patients can just kind of feel kind of run down or just not as energetic as they used to be. And it can be associated with other medical issues and also with medications. So some of the dopamine agonists, which is a class of medications that we use to treat Parkinson's disease, and that includes medicines like rotigotine or Nupro, Mirapex, pramipexole, ropinirole, or Requip. You might have heard some of these words or be on them yourselves. Though that class of medications has a side effect of causing sleep attacks, so that can cause sleep problems itself. Another possible issue is excessive daytime sleepiness. That can also be related to many factors. If you didn't sleep well the night before, then of course you're going to have sleepiness the next day. And then also if you're on any sedating medications, that can make you sleepy the next day. All right, so how would we test for sleep disorders? So your doctor might want to order a sleep study just to fully understand why it is you're either having trouble falling asleep or staying asleep. And that study can be really beneficial. Sometimes we can do it at home, or sometimes you might need to go into a sleep lab, and you might get hooked up to a couple little wires, and they'll put a video on you and watch how you're sleeping, and they'll count kind of how many limb movements you have. They count how many arousals you have, and then they look for apnea, which are those episodes where you stop breathing. And then they can make diagnoses such as obstructive sleep apnea or OSA, and they may make recommendations such as the need for a CPAP machine, which is that breathing machine that people with OSA wear at nighttime. Okay, so the most important thing that I cannot emphasize enough for patients with sleep disorders is that it's so essential that you have good sleep hygiene. And then once that's in place, if you're still having sleep issues, then you can start talking about medications or other interventions. But this is just every person, regardless of if they have Parkinson's or not, should be following these tips. So You need to make sure you have a consistent sleep schedule as best you can, to be getting up at the same time every day, even on weekends and vacations, making sure you're getting enough sleep. So setting that schedule. So if you have to wake up at 7 to work, then you need to be getting to bed, before midnight. You should go to bed once you're sleepy, but you shouldn't go to bed when you're not sleepy, because, or if you do and you can't fall asleep after 20 minutes, then you need to get up out of bed. And the whole reason for that is so that you're not laying in bed and associating not sleeping with your bed. You can have a relaxing bedtime routine. You should only use your bed for sleep and intimacy. You should not be watching TV in your bed. Try and make your bedroom quiet, relaxing, make the temperature comfortable. Try, if you can, of course, we all have computers and phones, try to limit your exposure to bright light and electronic devices at least 30 minutes before bedtime. Don't eat a large meal before bedtime, and avoid consuming caffeine or alcohol or too many fluids right before bed, because of course then you're going to be getting up to urinate throughout the night. Okay, so other than good sleep hygiene, the other things you can do are exercise. That really helps regulate your sleep-wake cycles. And then treat any other underlying medical issues that might be causing sleep problems. Like I mentioned, obstructive sleep apnea. If you need a CPAP, then that can really help improve your sleeping. Addressing any urinary issues, like if you're having a lot of urination at bedtime. Sometimes people need Parkinson's medications like carbidopa, levodopa overnight to help them with turning in bed. I think some people think, oh, well, I'm not moving. Why would I need medications at bedtime? Well, some people do need that just for that help and that comfortability moving around in bed. Melatonin is a really great medication for sleep because it's natural, it doesn't have any side effects, and it has been found to be decreased in patients with Parkinson's. And so that's something you can talk to your doctor about. You can get over the counter, and some patients will say, oh, I was taking 3 milligrams of melatonin, it didn't work, so I stopped. Well, sometimes we'll recommend that patients increase their dose, even up to 10 to 12 milligrams. And then there are rarely other medications that we will use for sleep, like clonazepam or Klonopin. You might have heard of that one. That one can be good, but it has been shown in the long term to have some cognitive effects. All right, now we're gonna switch from sleep over to some autonomic issues. So your nervous system is comprised of multiple parts, and one part is your autonomic nervous system, and that controls the things that we don't even think about that are happening in our body all the time, like your heart rate control, your blood pressure control, your digestion, all those things that your body just does automatically. So constipation is incredibly common in Parkinson's disease, and like REM sleep behavior disorder, or RBD, it's one of the prodromal symptoms. So often many patients will say, oh, I started having constipation 10 years before my tremor started. And the way that we define constipation is less than 1 bowel movement per day. So ideally everyone is having 1 bowel movement per day. And this is due to everything kind of slows down in Parkinson's, and that includes the motility in the gut. So if things aren't moving as quickly as they should be, then it kind of gets backed up and people get constipated. So the #1 way that we treat this is just by encouraging patients to stay hydrated. So if you can be drinking all the time, having a water bottle by you, that's sometimes a good reminder. Drinking throughout the day up until a few hours before bedtime, that is great. Another way is to add more fiber in your diet, or to eat smaller meals throughout the day rather than really big meals that can kind of get stuck in the stomach, because there can also be delayed gastric emptying, meaning food just kind of gets stuck in the stomach and takes a slow time to go through. And then if you talk with your doctor after doing those other interventions, there are medications that we can recommend, such as stool softeners, such as docusate, otherwise known as Colase, and then sometimes we use stimulants as well, such as Senna or Senecot. Bladder dysfunction is also pretty common in patients, both men and women, and it can have multiple different causes. And it can also be, the problem with the bladder can be that it's holding on to too much, or that it's only releasing small amounts at a time, resulting in frequency, or both. So why is this important? Again, like we already talked about, urinary frequency, if you're getting up all the time, that can lead to fragmented sleep and then tiredness the next day, and you can't get stuff done that you want to do, and kind of a cascade of things. And some people can have social embarrassment from that as well. In order to treat it, one thing that your neurologist might recommend is actually just to meet with a urologist, because there are so many reasons why people can have bladder dysfunction, and Parkinson's disease is just one of them. Another common one as men age specifically is that you can get an enlarged prostate, and that can, it's so common to cause issues with urination. And then other problems could be if there was a urinary tract infection. Other ways, as I mentioned, staying hydrated is important, but making sure to drink earlier in the day, cutting back on alcohol, caffeine, and carbonated beverages. And then we do have some medications that we use to reduce bladder overactivity. Sexual dysfunction can also occur in Parkinson's disease, and this can cause decreased libido or erectile dysfunction. And again, often we will recommend a visit with a urologist or gynecologist, just because there are so many other causes other than Parkinson's that could be contributing, and just want to make sure to be addressing those as well. Some of the medications that we prescribe commonly for Parkinson's, such as the serotonin reuptake inhibitors, and that's a class of antidepressants that are very common, and they can, in some patients, have a side effect of decreased libido. And then, of course, there are medications available to treat sexual dysfunction. Okay, another big one under this autonomic dysfunction category is orthostatic hypotension, and that is characterized by when someone kind of stands up suddenly, they just feel super woozy and lightheaded. And commonly this is related to dehydration. And also it can be worsened or just caused by the medications we prescribe. And carbidopa, levodopa, or Sinemet, which is probably the most common medication we prescribe, can worsen orthostatic hypotension in some patients. So the way we test this, and you might have experienced this, is that we'll check blood pressure when you're lying down, and then have you sit up for a second, recheck it, and then stand up, and then a few minutes later we'll check the blood pressure again. And then we kind of compare those three values, looking at your blood pressure and your heart rate to see how it has changed. So normally your blood pressure should stay about the same or should rise, because when you stand up from a laying down or seated position, your blood pressure needs to kind of increase to get the blood back up to your head. But if your autonomic nervous system isn't working properly, then the blood just kind of pools in your legs, and that's what causes that kind of lightheaded feeling. So for positive orthostatic blood pressure measurements, the blood pressure will drop or the heart rate will go up. And again, the best way to treat this is hydration. So making sure you're having enough water throughout the day, and then not dehydrating yourself with too much caffeine. Sometimes we may need to adjust your medications if the orthostatic hypotension is getting too much, it's getting to be too much of a problem because of the Sinemet or something that we're prescribing, then everything is kind of a discussion of risks and benefits. We may need to decrease that dose. We do have other ways to manage it. Often we'll recommend compression stockings that you could just buy online. As long as the patient, if you don't have, as long as your blood pressure doesn't get too high, we could also recommend increasing the salt in your diet, because that kind of helps the water stay in the vessels, and that increases blood pressure. And then we do have medicines that we can use to raise the blood pressure. The one thing to be aware of those is we usually don't recommend taking those at bedtime, because that's when you're kind of lying down and your blood pressure will go up. And we want to avoid something called supine hypertension, or having the blood pressure get too high when you're laying down. So usually if we're going to prescribe those medicines, we'll also recommend that patients lie with the bed kind of propped up at least 15 degrees. All right, and then the last topic we're going to talk about today is sensory disorders. So I don't really need to go into this too much, probably, because it sounds like Dr. Pellick, who is amazing, is going to come give you guys a talk on Wednesday, specifically about vision changes in Parkinson's. And we actually were just discussing an article that was published this month in our main journal about how common vision changes are in patients with Parkinson's. They're actually much more common than people of the same age. So, and there can be all kinds of vision problems that you might not think to associate with your Parkinson's disease. So patients can get blurry vision, and that might be due to decreased blinking, resulting in dry eyes. They can also have something called convergence insufficiency, where the eyes, your eyes are kind of supposed to line up and look the same way at the same time. But if they aren't kind of talking to each other and doing the exact same thing at the same time, that can cause some double vision. And that's part of the eye movement problems. We already talked a little bit about visual hallucinations and illusions. And then some patients can have impaired color discrimination. So things just don't quite look as sharp. And of course, vision is so important to our daily lives and just in general to your safety. It can contribute to problems with driving. It can also contribute to problems with walking, and that's why it's so important to treat it, because we want to preserve your quality of life and your ability to be driving and not falling. And it can, of course, be kind of disturbing if you're not perceiving things correctly. So the way to test this is by going to see specifically an ophthalmologist or eye doctor, and they can check visual acuity, so how sharp your eyes are if you need glasses, your eye movements, how well they kind of come together. And then they can also check for non-Parkinson's related issues like cataracts or glaucoma, things that just come up in some people as we age. So for blurry vision, we can treat this commonly with prescriptions, like maybe you just need your glasses or your contacts adjusted. For double vision, that convergence insufficiency I mentioned, some patients will have prisms added to their lenses, which it's just like a little extra piece of glass that helps the eye focus in the correct way. It's so important to treat dry eye, and I'm sure Dr. Pellick will go into that. But some patients, if you're not blinking as much, you're not having, the proper tear film, you might need to use artificial tears. And then treating other eye issues, like I mentioned, cataracts, other things that are treatable. And it's really important to make sure those are getting addressed, because having worsening vision can cause other issues. So some other sensory changes I'll address include decreased taste and smell, pain, and then restless leg syndrome. So patients with Parkinson's can have many different types of pain. A really common way that patients first might notice their Parkinson's, and this might happen to you or someone you know, is that they notice some shoulder pain on the affected side because there's stiffness there, and they might think that they have an orthopedic issue there and go see an orthopedic doctor, or get a shoulder surgery. We hear that all the time. But really it's just the stiffness, and because they're not swinging their arm in the same way that they were before. But it is still important to, you know, when if someone were to have pain there, to do a full assessment, like a musculoskeletal exam, and to look for symptoms like arthritis or tendon problems or other issues like that, to see if we can address those too. Restless leg syndrome. So this is an experience that people feel this urge to move their legs, and it's usually accompanied by some type of unpleasant sensation. Some people will say they feel like there's bugs moving in their legs, or everyone has kind of their own description of it, that they just feel the need to move their legs, usually when they're laying down at nighttime, when they're just resting, and then they move their legs and it's much better. And in order to have this diagnosis, there shouldn't be any other medical explanation for that. So how can we treat these things? So for the decreased taste and smell, unfortunately that's not reversible, but you could try adding salt or spices to increase the taste. And again, loss of smell, like constipation, like REM sleep behavior disorder, that's one of the prodromal symptoms that can kind of happen early on. Pain, there's many ways to treat it, because of course it depends on the type of pain that someone's having. You can try meditation or mindfulness, massage, range of motion exercises with physical therapy. Some people, like I mentioned, who have that shoulder pain from not moving the arm, can kind of do some gait retraining to learn to swing their arms properly when they're walking. And then we have pain medications that we can use as well. For restless leg syndrome, it often actually responds to dopaminergic medications like carbidopa, levodopa, or Sinemet, and then gabapentin is the other first-line agent that we'll use for that. And then just an important thing to note is that your doctor likely will check a ferritin level, which is a level of the storage of the amount of iron you have in your body. Because if you have low amounts of iron, that can actually cause restless leg syndrome, and it's very easy to treat just with iron pills. So overall, that was a lot of information. Thanks for those of you who stuck through it. What we want you to take away from this talk is to let your doctor know if you're experiencing any of these symptoms. We just hope that you can see that there are many different symptoms that can happen with Parkinson's, not just tremor or stiffness or walking problem, and not that everyone will get it, but that if you do get them, that we have lots of things that we can offer you. Always make sure to keep your medication lists updated, because as you saw, a lot of the problems can be from the medications that we're giving. So it might be as simple as reducing the dose or switching to a different medication. Another common theme that came up for a lot of them was staying hydrated, especially early on in the day, practicing really good sleep hygiene, and then of course exercising. Thank you guys so much, and we'll take any questions that you have now.
Okay, thank you so much for that presentation, both of you. I also want to mention just really quickly that although all of our in-person classes, exercise classes, are canceled, we do have some online Zoom classes available for people. So if you are interested or want to check them out, please just email me. We'll make sure that you have a waiver signed with us and send you the login information for those so you can stay active and moving during this time. It's hard. I'm struggling myself with it. So, but we're making do. Okay, so it looks like we do have a question here from Terry, and she asks, what can we do to exercise our memory?
Yeah, it's a great question. if physical exercise, just exercising your body can also help with your memory, even without doing specific memory exercises. Anything that keeps your brain active, in addition, things like crossword puzzles, Sudoku, jigsaw puzzles, and staying socially engaged, all of those things are ways to exercise your brain and memory.
Awesome. We don't have any other questions coming in quite yet, but we'll give it a couple of seconds just to get used to it. And again, if you can both submit the questions in the drop-down menu that's off to your control panel side, or if it's easier, we can unmute you if you raise your hand and have you ask the question verbally. Well, all right, so we don't have any other questions coming in quite yet, but if anything comes up, please feel free to email me back. There will be a follow-up email that will be sent out to everyone. Oh, never mind, we have a raised hand. All right, so we have a raised hand from Elaine. Elaine, I'm going to unmute you and then you can ask your question. Second. Maybe.
Can you hear me now?
Yes.
Yeah.
What types of pre or probiotics should we be using to help with gut?
So that's a really good question. As many of you know, there's a lot of research going on about the connection between the gut and Parkinson's. And there's one thought that the microbiome of the gut can contribute to the onset of Parkinson's. So some people wonder if that's one way that there's a virus or something that causes Parkinson's. It can enter through the gut and then kind of goes up into the brain. So a lot of people ask about probiotics, which I don't have a specific one that I recommend, but I think just getting one at like Whole Foods or something like that, I think it's a really great idea to kind of just make sure your gut is healthy too. And then, on top of that, making sure that you're having good bowel movements every day and, staying hydrated, like I was saying, and trying to have one bowel movement per day. If you need more fiber, if you need a medication, just doing that, I think overall helps with your gut health.
Elaine, did you have another question?
Yes. So are there certain types of probiotics that need to have a certain amount of what's it called, bacillus or something in it that's better than others?
I'm not aware of any, particular
Yes.
studies that have shown, one type or another type. I think it's just more like theoretical that we think that probably it's good to take probiotics, but I don't think, there's not really like controlled trials or something showing, oh, you should be taking this type versus another type that I'm aware of.
There's also
Okay.
such low risk with it that because of the theoretical benefit of having probiotics, we don't have a reason to not recommend it since it's safe, but we just don't know enough about it yet to be able to recommend a specific type of probiotic.
Okay, thank you.
Great, thank you. So we've got a couple of the questions that come in. Terry mentioned that she has lost her sense of smell, but she still has phantom smells. Is that normal?
Yeah, that can definitely happen. Anytime any kind of sensation is lost, people can have phantom sensations of that. For instance, if someone loses their vision suddenly, that area of the brain that processes sight is still trying to be active and trying to make sense of what's happening. And so people who lose their sight suddenly can have kind of phantom visions. So that can also happen with the sense of smell. I hope they're good phantom smells.
Me too. All right, and then we have a question from Janice that says, would you recommend milk of magnesia for constipation?
We do recommend magnesium sometimes. That's usually for more, further down the line if the constipation is really bad. But that's definitely something worth talking to your doctor about. And again, making sure you're doing those non-pharmacologic interventions first of exercising daily or at least 5 times a week and staying hydrated and having fiber in your diet, kind of doing those things first and then talking about supplements and medications.
Great, so we have a couple of raised hands. We'll start with Ann Watson, and I'm going to go ahead and unmute you, and then you can ask your question.
Okay, the question that I have, I hope you haven't already answered because I had trouble at getting on in the beginning, so I missed the first part of the webinar. But it has to do going back to the gut. I'm finding that I am kind of gagging and throwing up it can be as much as twice a day, usually in the morning and usually in the evening. It's not every day, and I can go for weeks without it happening, and then it seems to happen quite often. And I don't know what's causing that. I do take Protonics, and I split it, so I take 20 milligrams in the morning and 20 at night, hoping that that was going to balance the medication, because I have trouble taking medications. But I don't know why this is happening, and I read something that that's something that can happen because of Parkinson's.
Yeah, that's a good question. So nausea and vomiting, just like all the other symptoms we mentioned, they can happen in Parkinson's, but they can also be caused by, non-Parkinson's medical problems too. Right. So that's for sure something you should be talking with your doctor about. If you're on carbidopa, levodopa, or Sinemet, if you're just starting it, one of the most common side effects people experience is nausea. So it could be related to your medications. It could be related to how you're taking the medication. So sometimes taking the medicine with a little bit of food can be helpful, like crackers or something. Patients with Parkinson's also can have swallowing issues. So if you're not swallowing it completely, so it's coming back out, it could be related to that. They can also have delayed gastric emptying. So if the food's just kind of sitting there for a long time in the stomach and not going through and getting digested, that can result in vomiting. And then again, like you mentioned, it sounds like you're on Protonics, which if you have reflux, that can, by itself cause some vomiting. Mm-hmm. And then other kind of esophagus or stomach issues. So it's really important. You would need to talk with your doctor about it because there are multiple reasons, Parkinson's or not, okay, that could be related to.
Okay, thank you.
Sure, you're welcome.
Thank you, Anne. We have another question from Susan, and she's asking about your experience with, pardon me, this is a hard one for me, glutathione treatment.
Like glutathione?
Yep, probably.
I don't personally have experience with that. I don't know about you.
I don't either.
Yeah. I think that's a supplement. Oh,
gotcha. Oh, she said, yeah, I believe so.
Yeah, that I'm not sure about specifically with Parkinson's. I would have to look that up.
Okay. All right, so it looks like that's all of the questions that we had, unless somebody else has another question to submit. We'll give them a couple seconds just in case. All right. Okay, so I think that's all for right now, but thank you both so much for coming and presenting, taking a chunk out of your Saturday to present for us. And again, I want to mention that there are some handouts available, and a follow-up email will be sent tomorrow with both a recording of this session as well as a link to the handouts. And I'll see if I can grab the slides from you as well, if possible, to share with people, so we can make sure that everybody gets the information. Awesome.
Great. Thanks for having us.
Yeah, thanks so much, everyone. Stay safe.
Yeah, thank you.
All right.
Thank you.
Bye-bye.
Bye.